title of this lecture is Neuroimmunopharmacology of Opioids. My name's Mark Hutchinson. I'm a research fellow at the University of Adelaide and I head up the Neuroimmunopharmacology group. I hope after today's lecture you'll be fascinated by this developing topic of neuroimmunopharmacology of opioids. If you are interested, I really encourage you to go and do some additional reading of our recent review. It is a monster in pharmacological reviews. If you can't get a copy, please don't hesitate to send me an email and I'm more than happy to send you a PDF. This really covers the early studies of what we understand about the immune actions of opioids, right through to today's most recent developments of what we understand this critical role central immune signaling has for the modification of opioid pharmacodynamics. So as you know, opioids are used widely for the treatment of pain. Their use has increased substantially and continues to increase. And this is potentially good because more people are getting treated for their pain, but unfortunately this has an unwanted side effect of producing greater access to abusable agents. And oxycodone is getting the name of hillbilly heroin. It's really changing the perception of drug abuse, opioid abuse, to being a more safe, unfortunately, because it's just popping a pill rather than injecting heroin in the back street. What are these compounds we're talking about? Well, I'd like to make the distinction between opiates and opioids. This is a very important distinction. Opiates are only the compounds that come from the opium poppy, that being morphine, codeine and thebaine. They are 4,5-epoxymorphinins. Opioids, on the other hand, are both. Opiates can be opioids, but opioids can't all be opiates. Opioids are the naturally as well as the synthetic and semi-synthetic derivatives of these opioids. So we have things where we've modified the 4,5-epoxymorphinin structure to give us compounds like oxycodone, hydrocodone, or we have the fully synthetic agents such as the methadone fentanyls, for example. And of course we have our own endogenous peptide opioid system, and there's actually a fascinating literature suggesting that our bodies are also able to manufacture endogenous morphine. These agents act at the three main classes of opioid receptors, primarily expressed on neuronal, but they also expressed on non-neuronal cells, those being the mu, kappa and delta opioid receptors. The anatomical location you know, I'm sure, very well. And we have a very well described structure-activity relationship of 4,5-epoxymorphinin agents. Here we have a classic structure here, with the 3 position being critical for opioid receptor binding. So morphine, for example, has a hydroxyl group here, making it a very good opioid agonist. In contrast, codeine does not have this 3 position available because it's methylated and it requires O-demethylation in order to unmask the opioid active hydroxyl producing codeine to morphine. In contrast, the 6th position really doesn't seem to be important to the opioid receptor activity. Hence, morphine 6 glucuronide, so adding a big glucuronide here, is still opioid active, whilst morphine 3 glucuronide, having a glucuronide here masking this hydroxyl group, creates an inactive opioid metabolite. A concept that's important to realize is that opioid activity at neuronal opioid receptors is stereoselective. So from very early studies back in the 1960s, we understood that the pure minus isomer morphine, which is the naturally occurring morphine, it's the only morphine you'll find in the morphine tablets, is an opioid agonist clearly and produces analgesia, whilst its fully synthetic derivative plus morphine has no significant neuronal opioid receptor activity, about 10 to 100,000 fold reduction in activity, and therefore doesn't produce any analgesia. Currently, the only opioid medication that has both isomers contained in it from an economic rather than scientific perspective is that of methadone. So only half the dose of methadone is pharmacologically active at the opioid receptor. But as you know, opioids don't always do what they're supposed to do. There's evidence now suggesting that opioids in some situations don't provide very much increase in quality of life. There's definite evidence to suggest that development of tolerance, and clearly there are certain disease states in which opioids are less responsive, such as neuropathic pain. Of course, we know chronic opioid administration has the potential to produce an abuse situation with the development of an addiction dependence, and there is growing evidence, whilst it's highly debated still, that certain populations develop opioid hyperalgesia, the atypical pain response following opioid exposure. Methadone maintenance patients, it's very well established, but in chronic pain populations it seems to be tricky to really nail down what's going on. But nonetheless, there is evidence that this potentially occurs. Now, a lot of work has been done to try and explain from a neuronal perspective what's happening to create this opposition of analgesia. A lot of excitatory amino acids you'll recognize here that are often associated with neuropathic pain have been postulated as mediating and contributing to the tolerance, hyperalgesia, allodynia, etc. associated with chronic opioid exposure. But these hypotheses have all assumed that this occurs downstream from opioid receptors. What I'd like to suggest to you is perhaps that's not entirely all that's happening. Let's take an example where we have deleted all the opioid receptors. So we have a triple opioid receptor knockout here, presented here, data by Waxman and Juni. If you were to administer an opioid agonist to an animal that lacks any opioid receptors, you would hypothesize that the receptor it's acting at is absent, so you should see no effect. And yet, after an acute administration of fentanyl, triple opioid receptor knockout animals get profoundly hyperalgesic acutely, and then if you repeat this administration over several days, these animals become hyperalgesic. Interestingly, if you do this with oxymorphone in the TLR in the triple opioid receptor knockouts, you get hyperalgesia immediately, whilst in the wild types you get the transient analgesia across several days, but acute tolerance develops after repeated administrations, and these animals eventually develop hyperalgesia. In fact, if we go back to the very first paper talking about the stereoselectivity of opioids, this group from Japan demonstrated that yes, you get nice analgesia after a dose of morphine. However, if that dose of morphine is combined with a dose of the opioid inactive isomer of morphine, that morphine response is completely ablated. So what this suggests to us is that perhaps all these things that are going on with opioids are not all about the opioid receptor. Now, this research has taken quite some time to develop. We've understood the involvement of non-neuronal cells in chronic pain since those studies from Garrison in the mid-90s, but it took a little bit longer for the studies really to establish something similar going on with opioids. In Fairbanks, late last millennia, what they showed was that repeated administrations of morphine intrathecally produced acute tolerance upon the probe challenge of morphine, and this is represented here by a saline-treated animal receiving analgesia after an acute morphine challenge, but the tolerant animal clearly displaying less analgesia. Excitingly, though, they showed that intrathecal administration of interleukin-1 receptor antagonist dosed time-dependently, depending on how long administered the agent was able to reverse this tolerance. Also, very interestingly, they showed that this inflammatory cytokine involvement may also be involved in cross-tolerance between opioids. So here we have an animal again that's animals that again have been chronically administered morphine and then have received a challenge dose of Damgo, the selective mu-opioid receptor agonist peptide. You see this cross-tolerance to the analgesic efficacy here. But if these animals receive either interleukin-1 receptor antagonist or so blocking IL-1 or the anti-inflammatory cytokine interleukin-10, both of these reverse the tolerance, the cross-tolerance to morphine with the analgesic efficacy of Damgo returning. So this implicates a pro-inflammatory response at the spinal level in the opposition of morphine action. This data was taken a step further with the work of Song, who showed that glia were involved in this response and potentially the source of the cytokines. What they did was they chronically administered morphine to these animals, and they looked at behaviour and immunohistochemistry. And if we look at the immunohistochemistry first, here's the basal background level of GFAP expression on their astrocytes and their animal spinal cords. After chronic opioid administration, in this case morphine, you see a significant upregulation of this astrocyte activation marker. And if they use a drug fluorocitrate to block that astrocyte activation, they get a reduction in the expression of the astrocyte activation marker. Interestingly, this decrease in astrocyte activation marker expression was associated with a change in behaviour. So here we have a morphine challenge in a vehicle-treated animal or a fluorocitrate-treated animal. You see you get lovely analgesia, as one would expect. Chronic morphine administration creates decreased analgesic response in these animals, hence tolerance. But chronic fluorocitrate administration with the morphine has resulted in an attenuation of the development of tolerance. So therefore this implicated astrocytes in the development of this tolerance response. Developing the story even further, lots of groups have shown this, but Choose is one of the nicest. What they showed was that microglia were also pivotal to this response. What they showed was, here is a chronically morphine-treated animal where they've looked at the phosphorylation of P38. P38 is a mitogen-activated protein kinase. They've done a double label here for the microglial activation marker CD11B using the OX42 antibody, and here's a saline-treated animal versus a chronic morphine-treated animal, and you can clearly see the upregulation of the glial reactivity in this microglial reactivity in this dorsal horn. And then they've used dual labeling to identify which cell types this P38 signal is actually expressed in. And so here you've got a neuronal marker in green and the P38 in red, and there's no overlap. Here we have an astrocyte activation marker GFAP with the phosphorylated P38. There's not a great deal of overlap, but when they use the CD11B overlaid with the P38 phosphorylated form, you can see there's significant overlap between the two. So this was an associative link that P38 was involved. They then came in with a P38 pharmacological inhibitor and showed that it blocked the development of tolerance. So therefore there's a clear role just from this snapshot of the data. There's a lot more there, and I encourage you to read the review paper we've written if you're interested, to suggest that there is a clear role for glial and pro-inflammatory responses as a consequence of chronic opioid exposure. But what my specific interest in this area was what happens within the first few seconds, if not minutes, of an acute opioid administration. So we developed a model of that enabled us to assess quite nicely this effect. We chronically catheterized rats with an indwelling intrathecal catheter. This catheter was then able to be loaded with opioid so that we could deliver the opioid, and then we could load bubble and give a secondary administration at some point in time remotely of another agent, and in this case it was the anti-inflammatory cytokine interleukin-1 receptor antagonist, hence blocking interleukin-1. We were then able to assess using a thermal readout on the tail and hind paw the latencies to response. So here what we have is pain responsivity on the y-axis and time on the x-axis. What you can see is after the intrathecal administration of morphine, we get a nice analgesia that lasts about 100 minutes. But then, and this is what we would expect to get in an ordinary animal model. But then what we did was we administered interleukin-1 receptor antagonist. And what we saw was there was a profound unmasking of continuing opioid analgesia that lasted out to 200 minutes. So what we were therefore seeing was that morphine was inducing an acute pro-inflammatory response that immediately, very rapidly, perhaps even immediately, opposed the analgesic efficacy of morphine. We expanded this out much further, so we looked to see that this wasn't just something limited to morphine. It also occurred to methadone, so we could unmask continuing methadone analgesia. It wasn't something unique to intrathecal administration. We were able to give morphine subcutaneously and give interleukin-1 receptor antagonist intrathecally, and we could see the unmasking as well. We also were able to establish that this wasn't just interleukin-1. We could use TNF-alpha blockade or interleukin-6 blockade, and we also saw this unmasking of continuing analgesia. To quantify this opposition of analgesia, we constructed a dose-response curve to morphine with increasing doses intrathecally and a constant dose of interleukin-1 receptor antagonist. And what you can see here is that the ED50 for morphine intrathecally in a normal rat is about 5 micrograms. But if we co-administer that with interleukin-1 receptor antagonist, that drops about 8-fold to 0.6 micrograms. So it's quite a profound shift. What also works well is if we block other pro-inflammatory events. So morphine co-administered with minocycline, hence blocking the microglial reactivity, we're able to fully potentiate the analgesic response of morphine. If we block fractalkine, the neuron to microglial signal, we're also able to potentiate the analgesia. Nitric oxide and P38 also all appeared to be involved in this response. Critically, if we administer them together, it suggested that these signals were all playing a role from the word go. So the working hypothesis we have is that after an acute administration of an opioid, we have two events. Firstly, we have the potential analgesic action of the morphine over time. But unfortunately, at the same time, we have this generation of a pro-inflammatory response. And what the two of these sum together to produce is a curtailed behavioral output, such that we might see a decreased maximal analgesia, and definitely the length of the analgesia is decreased. However, if we block this pro-inflammatory response using interleukin-1 receptor antagonist, or generally wiping this out somehow, we're able to unmask this continuing analgesia. So what we now hypothesize is that opioids are not only acting at the neuronal opioid receptor system, but they're also to produce analgesia, but they're also acting at this glial site that results in the production of pro-inflammatory cytokines. These cytokines can go and activate other glia that perhaps aren't opioid sensitive, thus translating at the presence of the opioid. And these cytokines then have a neuronal site of action, or perhaps astrocyte of action to dysregulate excitatory amino acids such as glutamate. And this then results in a pro-nociceptive neuroexcitation result in decreased analgesia. However, if we then block those with interleukin-1 receptor antagonist, what we're able to do is stop this pro-nociceptive result occurring, and we get either unmasked or potentiated analgesia. What happens chronically? Well, as I mentioned before, it's demonstrated that methadone maintenance patients are hyperalgesic. That is, they have a much greater response to a painful stimulus. And we can simulate this in rats by chronically administering morphine to these animals over several days, and they become basically allodynic to the same degree as a nerve injury we've done with chronic constriction injury. However, if we co-administer these doses of morphine with agents that block the pro-inflammatory response, such as interleukin-10 combined with interleukin-1 blockade, or a peptide that stops interleukin-1 being converted to its mature form with interleukin-1 receptor antagonist, we're able to completely attenuate the development of hyperalgesia. So in the chronic setting, we believe that the morphine repeated administrations produces gradually greater and greater pro-inflammation, and if we sum the two of those together, what you can see is that you get the development of analgesia. That is, we get decreased peak analgesic effect, and eventually we have a pain threshold that's below the original baseline, suggestive of hyperalgesia. And if we remove this pro-inflammatory emphasis, we hopefully would then unmask a far more beneficial analgesic response. So therefore, these data suggest it's not all about opioid neurons, and it's not all about opioid receptors. I hope you can also see that there are situations in the literature where existing pro-inflammation may profoundly alter the analgesic efficacy of opioids, such as neuropathic pain, as we've discussed. But what remained elusive was, how were these glia becoming activated? Now, this is a very long story, and there are multiple converging lines of communication and being in the right place at the right time. I won't go into it all in detail, but basically where we hit upon was that toll-like receptors appeared to be a potential target for our opioids. So we went through various stages of development, and the idea was, okay, so if we have an opioid agonist acting at this site, and we had shown previously that this action of opioids was non-stereoselective, so both plus opioid inactive and minus opioid active isomers of opioid agonists were able to produce this glial reactivity. We proposed that perhaps the plus isomer opioid antagonists, such as plus naloxone or plus naltrexone, both of which are not what are clinically used, they are not in the current clinical formulations, these are purely synthetic opioid inactive drugs, we proposed that perhaps these drugs might be able to block TLR signaling. And that's exactly what we showed in some cell lines of TLR4 expressing human cell lines. We also had some parallel work using in silico computer modeling to TLR4. So what we have here is a TLR4 molecule with its accessory protein MD2. And what you can see here is that morphine is docking into the LPS binding domain of MD2 in exactly the same position that LPS occupies. So what we therefore proposed was that a TLR4 blocker, like plus naloxone or plus naltrexone, could be applied to the system, and this would then shut down the glial reactivity. An opioid, a TLR4 blocker shouldn't bind to the opioid receptors, especially if it was a plus opioid ligand, because of the stereoselectivity of opioid receptors. And thus, when we came in with an opioid minus isomer agonist, we would get lots of analgesia, and we wouldn't see this development of pro-inflammatory cytokines, and hence we would get lots of analgesia. And that's exactly what we saw in our animal models. So if we gave morphine systemically, we get a transient analgesia at this dose, but if we combine that dose with plus naloxone systemically, we get potentiated analgesia and prolonged analgesia. If we do this intrathecally, we get transient analgesia, as we saw before with morphine intrathecally, but if we give plus naloxone with this, we see potentiation and prolongation. And excitingly, if we give morphine subcutaneously and plus naloxone intrathecally, we also see potentiation, suggesting that there's a spinal site of action potentially here. This has also been validated using various other molecular techniques. So we have two types of specific TLR4 pharmacological blockers here. Both of them produce potentiation of the analgesia. We have here a peptide inhibitor of TLR4 signaling that also potentiates the analgesia. And there's the plus naloxone data I just showed you before. What we now understand is there's a lot of evidence to suggest this TLR4 signaling cascade is involved in modifying opioid responses. What we know is we know a lot about TLR4 because of the critical role that TLR4 has in peripheral immunology and sepsis. TLR4 requires LPS binding protein to deliver LPS to the TLR4 MD2 CD14 complex. This signaling cascade requires heat shock protein 90 and 70 to translocate the signal. MyD88 is a key adapter protein for MyD88 dependent signaling, which occurs via the MAP kinases to result in MAP kinase and NF-kappa B activation. There is also a MyD88 independent pathway, but we understand less about this. And there are several studies which are covered in this particular image, but are covered more in the review article, that discuss how each of these show that the TLR pathway is critical for modifying acute and chronic opioid analgesic pharmacodynamics. So this is a fascinating point of convergence between opioids and chronic pain. Since, as we talked about previously, TLR4 is critical activator of Glia following a nerve injury, so is TLR4 involved in changing opioid responses. So are we in fact adding oil onto the fire by giving opioids to people who already have existing neuropathic pain? The clinical data suggests that these agents don't work well in these people, but are we producing a longer-term problem by doing this? We simply don't have the data yet, and we're trying to generate clinical data to support this hypothesis. Nonetheless, this viewing opioid and chronic pain generation with this information in mind helps us explain perhaps why we see non-responsive pain patients to agents that theoretically should be eliciting fantastic analgesic results. What this is also doing, our understanding of opioid action, is unmasking some other mysteries about opioid responses. So for example, if I go back to the opioid metabolites we talked about before, morphine 6-glucuronide, putting a glucuronide onto the 6 position here, fantastic opioid analgesic. However, putting a glucuronide on the 3 position produces a opioid receptor inactive metabolite of morphine 3-glucuronide, but is also producing an agent that is known to be associated with a wide variety of clinical data support this, an agent that is associated with hyperalgesia, dysphoria, seizures, etc. Many side effects of morphine use. What we showed in our animal models was that yes, we could replicate M3G-induced hyperalgesia with very low doses of morphine 3-glucuronide intrathecally, producing this hyperalgesia. But what was exciting was that we could actually give interleukin-1 receptor antagonist and reverse this hyperalgesia, suggesting for the first time that interleukin-1 was involved in the pro-nociceptive activity of M3G. We then also looked at whether this effect could be mediated by microglia, and yes, in fact it was, because it was minocycline sensitive. We've also gone on to show that this is in fact a TLR4 selective phenomena as well, through in silico docking simulations and with the use of pharmacological inhibitors of TLR4. So this produces an interesting situation when treating chronic pain with opioids. We know that chronic pain is initiated and maintained by glial pro-inflammation and appears to be TLR dependent, and yet the frontline pain treatment of opioids unfortunately causes neuroinflammation, central immune signaling, and also appears to be TLR4 dependent. And so this is a real point of research that needs to be greatly investigated in the clinical domain. So I hope you can see now that we've talked about this. We've covered central immune signaling and the pain, the cell types that are involved, cytokines, the signals that are involved, and touched on perhaps the why and the significance of this. We've also talked about opioids and the interactions between brain and immune communication and the implications this has for pain as well as opioid responses. However, there's a growing list of other situations where glial reactivity and brain to immune and immune to brain interactions are becoming critically important. And here's a list here. What I would expect would be that many of you will be exposed to individuals who have one or more of these ailments, and given that we now understand more about the complexity of the central immune system as a fascinating mediator between different neuronal systems, between peripheral and central pathologies, I hope that you can see that perhaps the importance of understanding what is happening to the immunology in these individuals. Perhaps you can understand that there may be an explanation for an odd response, and that there might be an explanation for the lack of pharmacological efficacy of particular neuronally targeted agents. So if you are interested in this area, I encourage you to read this review. If you're generally interested in the topic of psychoneuroimmunology or neuroimmunopharmacology, please don't hesitate to email me. I'm more than happy to provide you with further information. Thank you very much.